Most people in the world have experienced low back pain at least once in their lives, about 1 in 13 people, and it is the leading cause of disability. Physiotherapists are experts in treating and guiding patients with pain to recover and improve their functionality. Therefore, this year, the World Physiotherapy campaign for World Physiotherapy Day focuses on low back pain and the physiotherapist's role in its treatment. Despite low back pain being among a common reason for consultations, there are still questions to address, such as what are the most effective interventions for treating low back pain? What actions are necessary to resolve this global health problem? And what factors influence the development of back pain and the patient recovery? To talk about this, I'm with Dr. Giovanni Ferreira. He is a physiotherapist trained in Brazil with a PhD in medicine from the University of Sydney. Also, he is a National Health Medical Research Council Investigator Fellow. His research focuses on evaluating the effectiveness of commonly used but poorly investigated interventions for pain conditions. My name is Maximiliano Sánchez, a physiotherapist from the School of Medicine of the National Autonomous University of Mexico. Giovanni, thank you for joining us today. We truly appreciate your participation and valuable insights.
Hi, Carlos. Thanks so much for the invitation. I'm really happy to be here and to talk to you about back pain.
Great. So let's start with a personal concern because we have read a lot of randomized control trials, systematic reviews, guidelines, even reviews of guidelines.
Yeah.
But if there are a lot of evidence about treatment for low back pain, why does it remain the first cause of years of life with disability worldwide?
That is an excellent question, and I'm going to break the question into two parts. In the first part, I'll talk a little bit about what this thing that we all talk about, burden of disability or burden of back pain, is and means, and then we can talk a little bit about the evidence and the amount of evidence that's available. So when everyone must have read at some point or heard someone talking about the burden of back pain keeps increasing. This usually is in reference to a big study called the Global Burden of Disease Study, which is a study that measures disease burden for a number of conditions, including back pain and other musculoskeletal conditions as well. And that study uses a particular methodology that takes into account mostly the prevalence of back pain and the number of people with back pain in any given area in a country over the years, etc. When people say that the burden of back pain is increasing, that doesn't necessarily mean that the prevalence of back pain is increasing globally, right? Or that the incidence of back pain is increasing globally. It means that the population is increasing, the aging population is increasing, and therefore the number of people experiencing back pain in total is increasing a little bit, but that doesn't necessarily reflect a change in the prevalence because, at the same time that there's more people with back pain, the population is increasing. So in fact, if you read the latest Global Burden of Disease study that focuses on back pain, you'll see that the prevalence of back pain that's adjusted by the change of time and that's adjusted by the aging of the population, the prevalence is actually decreasing slightly. Which I think is great news, right? I think this could be partly due to treatments for back pain improving, and perhaps in some regions of the world, people becoming more aware and taking up more, I guess, healthy behaviors that prevent back pain from coming up in the first place. So that's one thing. So there is more back pain, or there is a higher burden of back pain that keeps increasing because there's more people alive on Earth at this point in time than in 20 years ago, but that doesn't necessarily mean that back pain is becoming a worse problem. That's one part. Second part is in terms of the evidence and the amount of evidence that's out there, and I think we can all agree, and you've done some research on that, the number of studies that gets published every day in back pain is just ridiculous. There's so many studies getting published every second. And obviously there's a lot of high quality studies. Most of them don't have a very good quality. It don't really inform practice. But I think at this point in time, we kind of know what works on average for people. And, you know, we know that the evidence for interventions, physiotherapy interventions is pretty good on average in terms of exercise, in terms of education, in terms of self-management. These things, they help on average a bit. For some people, they help quite a lot. For some people, they don't help at all. For some people, they help a little bit on average. But, you know, population-wise, I think these interventions are quite good.
Okay, that's an interesting response because it's true, the low back pain incidence is increasing because people in the world is increasing. Every year we're more in the world. Yep. And this influencing the incidence of back pain. But it's a good news that the incidence of low back pain is decreasing if we stratify in age, or considering the age. And we talk about the quality of randomized control trials about certain interventions like education, that it's a lot of people talk about the education is nowadays one of the most effective interventions for back pain. So my question is, what are the most effective educational strategies for patients with low back pain?
That's a really good question, and it's a very broad one. I think when people say education, there are a lot of things that fall under that umbrella. You know, I like to separate education into a few components. So, for example, I think it's good practice, and everyone should do, you know, when seeing someone with back pain and when studying back pain, is knowing that, you know, if you did a thorough physical examination and you didn't find any reason to be concerned about that person's back pain, so if there's no red flags or any additional concerns, I think the next thing that any health professional should do is to reassure the patient about, you know, the likely prognosis of back pain if that person is experiencing an acute episode, for example. We sort of know that the prognosis is typically positive, so people tend to get better within the first 6 weeks, and a lot of people will recover. So reassuring people about the prognosis, about the nature of back pain, trying to, I guess, dispel the myths that, you know, that there's things wrong with the back, that your back is broken, or those things that a lot of health professionals love saying, you've got the back of an 8-year-old person. So if we can, I guess, do the very basics and reduce threats, or all the threats that having that label of back pain bring to a patient, I think that's a pretty good job, and reassurance is an important part of that, reassuring people. And that falls under education. And then there are other education approaches. For example, we've got pain neuroscience education that may help. I think there's some evidence showing that it helps, some other evidence showing that it doesn't really help that much. I personally, but people may disagree with my view, but I personally think the jury is still out, and you know, this concept of pain neuroscience education is very patient dependent. You will have people who will absolutely hate the idea of learning about how the brain works and what pain is and that kind of stuff. Some people will find it really interesting and will use that to understand better about their condition and then change their behaviors as a consequence. But I think it's an overall an okay strategy to test, and that's shown to be, you know, positive in a few studies. But overall, I think, yes, education is a powerful thing. Doing the very basics of, you know, reassurance and educating people about the prognosis and things, I think it's, in my opinion, the best educational approach that you can take. Other things, more complicated approaches, they can be perhaps adjunct interventions, but then you sort of have to navigate your way and have a feel about, which patients are good patients for those more complex interventions, I think.
Yeah, that's interesting. This part of reassurance of people that we are not broken bodies. We are alive bodies, and we can. And most of times, our back pain is not worse like than we imagine in the most of cases, and this is something that we have to transmit and to communicate to our patients. And talking about these messages and these other strategies like educate people about pain sciences, there are other messages like ergonomic messages about change the workplace, put some stuff to improve the workplaces. How do you think about these messages and about these strategies about ergonomics?
Yeah, that's a really good question. Last year, our team published a study in JOSBT where we compared 3 different ways of providing reassurance to people. One of them was just providing simple guideline messages, things like, I'm not concerned about your back pain, the prognosis is likely to be positive, and messages around that reassurance bit that I just talked about. A second group got that, and in addition to that approach, they also got some pain neuroscience messages, and where we sort of tried to briefly explain where the pain was coming from, and in terms of the brain processing, and that we try to tease out the concept, I guess, of the pain and injury. They're not necessarily the same thing. You can have a lot of pain but no injury. You can have no injury but a lot of pain, and you can have a big injury but not a lot of pain. Sorry. And then the third group of people, they got those guideline messages in terms of reassurance, but we also gave them some advice about ergonomics, like ergonomics-based advice, and things like, you have to look out for your posture. You have to be careful with how you move. You have to, I guess, make sure that you practice safe lifting. If you're overweight, this puts pressure on your bones, on your spinal bones, etc. So we did this randomized study, and we looked at how much reassurance these 3 different approaches gave people, and we found that for most outcomes there was no difference at all in terms of all 3 approaches. There was one difference, which was small, but it was a difference anyway, which was when comparing just simple guideline messages with ergonomics messages, we found that there was a small effect of ergonomics messages in terms of decreasing reassurance. So it made people less reassured that it was safe to move because of their back pain. And I think we think this was probably the first experimental in the context of like a randomized study that showed that this could happen, that this sort of advice could be potentially harmful. But a lot of people have been saying this for quite some time, that really this type of advice, in terms of watch your posture, be careful with how you lift things, and on a daily basis, that really isn't really helpful, because it adds a lot of tension and a lot of pressure on people. It makes people more extra aware of what they're doing and how they're moving. And we are, human beings. We're not supposed to be thinking about how we move. Should we, bend our knees when picking up a pen off the floor, and that simple kind of stuff. And I think this study that we did sort of provided some experimental evidence that this can actually become a problem.
Okay, this is an interesting finding about this study that you and your team have done. And talking about this difference about the group with ergonomics-based messages and the other group guideline-based guideline based. Do you think that if we give to the patient messages about ergonomics, but in a with measure or with in a fair manner, this kind of reassurance could improve their pain, or is recommendable that we as our clinicians avoid these messages in the treatment of our patients.
Okay, so in terms of just talking about the findings of that study that I just talked about, we didn't measure pain, and I don't know if there is any data showing that giving people this sort of advice, focusing on ergonomic principles, would have an effect on pain, be it reducing or increasing pain. I don't really know. What we did show was that there was a small effect on, it made people slightly less reassured. So, in our study, it wasn't a good approach in terms of, reassurance. I think in practice, obviously, studies, especially randomized studies, they show you what happens on average, right? But in the clinic with patients, you have to make decisions for that one individual person in front of you based on data from studies that are the average of a sample, right? So I think obviously you want to, you need to interpret the findings and make a decision about whether those findings are applicable to the patient in front of you. So for example, if you're treating an older person who, doesn't, I guess, lift a lot of weights on the, apart from the normal daily activities, and they are concerned about, should I pick the grocery bags off the floor and just, move them around and that kind of thing. I think there's probably a justification for you to perhaps suggest that shouldn't be too big of a concern, because, you're talking about that particular person. But on the other hand, if you're treating, I guess, a weightlifting athlete who lifts 300 kilos many times a day, that kind of patient, it has to be a different approach, right? So there are then, I guess, ergonomic principles. You might want to focus a little bit more on that biomechanics side of things to advise and to correct the lifting technique and whatnot. I think you always have to interpret the evidence in relation to what you have to do with the patient in front of you. So I think these are two extreme examples, but I think that's the best answer I can give in relation to that. You have to, there's no blanket statements, and whenever people just use research findings to generalize research to every other situation, I think that's wrong, and you have to be able to make that individual call for the individual person in front of you.
Yes, that is a good advice. Totally agree that we can see some effect in a randomized control trial, but in the clinic, this effect could appear, but depends of the necessities and the concerns of the patients, the decisions that we have to make. That's the principle of evidence-based practice, indeed.
Can I just add one point?
Yeah, of course.
Sorry. I was just going to say the reason why I mentioned, the fact that trials, for example, give us an average effect, but then we have to translate that into something that will be done to an individual person. That doesn't necessarily mean that at the end of the day we can just ignore research, right? What research will tell us, and what trials, for example, will tell us, is that if an intervention is harmful, for example, on average, what you should expect from the patient in front of you is that on average, there is a higher chance that that person in front of you will be harmed by the intervention. So you can't just use the individual variation or response to treatments that, as an excuse to completely ignore research and do whatever you want to do. I think it's just an issue of interpreting the research and applying to your patient. But I think research is obviously a key piece of information that you shouldn't ignore.
Of course, and I want to say thank you to emphasize this point. Of course, to have an evidence-based practice, we have to interpret, read and interpret the evidence and combine with the concerns and the necessities of the patient, even and with our clinic expertise. But of course, we have to consider the findings of the evidence, of course. And well, talking about this part of the concerns of the patients, in your experience on research and clinical experience, what kind of concern, what are the most common concerns of patients with low back pain that physiotherapists should consider in the treatment plan?
Yes, that is a really good question. I think probably the most important thing is to obviously listen well to patients' concerns without jumping at conclusions before hearing from the person in front of you what's concerning them. It's very common, and I've done that in the past as when I was practicing as a clinician a number of times. I knew what the guidelines say, for example, in terms of, you should reassure people that they don't have a serious spinal pathology, they don't have cancer. But a lot of times I would just say that. I don't think I don't think there's any cancer here. And the patient will look at me and say, I never thought there was cancer in the first place. So you've added a little bit of a concern, an extra little concern to the patient, right? The patient will be thinking, why did he tell me that there's no cancer? Like, why is he concerned about that? Should I speak to somebody else? Should I go do a scan? So I think the first tip is to listen first and talk later. And then, we did some research on what sort of concerns people have, and a lot of the times they don't necessarily align to what the back pain guidelines tell us to tell people. So, a lot of people, they're concerned as you and students, as a student is studying to become physios would know from seeing patients and placements and things. People are concerned about the effects of aging on their back pain. They're concerned about whether their daily activities will make their back pain worse. There's a lot of different concerns there, are not necessarily the ones that guidelines mention in terms of cancer, fracture, that kind of thing. And I think you just have to listen to the person and then provide tailored advice, and not just a cookbook recipe sort of advice, because chances are if you just do that, you're not going to address the person's concerns. They're not going to be happy with what you're saying, and it just creates issues, I think.
Of course, that's a good advice to first to hear the patient before to start give them a lot of red flags about the guidelines said,
Yeah,
because
exactly.
they could start to thinking that may have these red flags, of course. But we have to first start to hear the patients, hear the concerns of the patient's concern, and for guide these patients in the rehabilitation process. And talking about these red flags that the guideline says, what are the red flags that we have to consider to refer the patients to the specialist? Because when we start the diagnosis process, what are these red flags that we have to have in mind to if we detect them,
Yeah.
we could refer the patient in an opportune manner.
I think this is a really, really important question. And as physiotherapists, we should be talking a lot more about this. And especially, I don't know what the situation is in Mexico, but in a lot of countries, there are now pushes for physios to extend their scope and work in settings that they didn't used to work before, like hospital, like emergency departments, or in the UK, you have the extended scope physios who can, prescribe certain medications, do injections. So they have an expanded role, right? But with that responsibility, with that bonus, I guess, comes a big responsibility, because people will start coming first to see a physio, and sometimes they will have a serious disease, and the physio needs to have training, adequate training in recognizing these things. Now, I think it's a bit of a tricky situation, because when you look at the latest Cochrane review on red flags for back pain, there isn't much apart from a few red flags for detecting cancer and fracture. Like, there's a cluster of red flags, for example, for fracture, which is, age, using corticosteroids, having had a fall recently, and these are good. And then, the red flags related to cancer diagnosis are a bit more murky, like feeling unwell, I guess, of the clinician. So there's some of these red flags, but there's a whole lot of other conditions that are very serious, that are life-threatening, and a patient with back pain could be experiencing one of those conditions, could have one of those diseases, and they're just masquerading as back pain. And I don't think guidelines and they provide adequate guidance on that. So, for example, a complication, a disease that's common in people who present to emergency departments with back pain is an abdominal aorta aneurysm, right? That's a fairly common issue that happens in EDs, not so much in primary care or in physio clinics, because people go to the hospital and they feel like they've got that. But there's no red flags or validated good red flags to diagnose that. So I think there's a lot of training that's required. I don't think overall physios are well trained to detect those things. And I think there's a mindset issue, right, that separates physios and, for example, doctors. A lot of the times doctors, they may investigate people more because they start from the premise that there is something wrong with the patient. And then they do the workup and they find out that there's nothing. I think a lot of the times physios have the mindset that there's nothing wrong with the patient. And that's the initial premise. And a lot of the times we just skip a proper physical examination, don't ask the right questions. And, most of the times it won't be serious, but for that one time that it may be, it could be complicated. So I think we do need to talk more about specific training to detect those things, be trained with medical professionals on these things. And again, there's no validated red flags for a lot of these conditions. It's more about clinical experience. It's more about some, generic signs and symptoms, but we need to talk more about that, that's for sure.
Okay, that I totally agree that it's important to diagnose these red flags, but it's necessary to have a good training to make this process the better process to reach the right diagnosis and give a patient a good advice. And well, the physiotherapist could expand their role, their traditional role, and Talking about this, what about in Australia? Does physiotherapists participate in the team of emergency department in Australia? For example, in Mexico, physiotherapists don't participate in emergency departments because in the first training we haven't this specific training in emergencies. So what about in Australia? Is quite similar or different?
No, it's different. It's becoming more common to have physios working in EDs, and they can work in two different models of care. They can be, most commonly they are what we call like a secondary protection, like a second contact protection, which essentially is the patient gets triaged by the nurse when they get to the hospital, and then they are seen by a doctor. And if the doctor doesn't think that there's anything serious, they would then refer the patient to the physio in the ED to start some initial analgesia to advise the patient on whatever needs to be advised. This is one model. There's another model, which is the first contact protection model, which involves, the patient turns up to the ED, is triaged by a nurse, and is referred directly to the physio if the nurse doesn't think there's anything serious. So you bypass that step where the doctor assesses the patient. And I think that's, there's quite a lot of that happening at the moment. I think overall it's a safe approach that can make, I guess, the flow of that can, you're getting older musculoskeletal pain patients, for example, diverted to physio, so you can leave ED doctors to deal with heart attacks and other more serious problems. But again, I think there's a question there about, are physios well trained enough to be able to have that responsibility of being the first contact for that patient and realize that they may need to refer again to a doctor or escalate that patient because there's something serious going on. And I think that's a big discussion happening at the moment.
Okay, and in the physiotherapy schools in Australia, their students are trained to participate in EDs, or is something that is that is developing now?
Yeah, I don't think so. I don't think there are any ED placements. I think this is more of these are usually senior roles of physios who work in the hospital in different departments that they get pulled into the ED, or I don't think there's any university training. It's more of a role that opens once you are like a hospital employee, and but no uni training as far as I'm aware.
Okay, that is very interesting, and the difference in the organization of different countries. And well, talking about education, I would like to return to this topic, because in the patient usually, or unless in Mexico, the patient usually start to search their symptoms of low back pain to try to explain why they have low back pain, and they start to find a lot of information. But what about this information that is available to all of us? Do you think that misinformation on the internet about low back pain for the general public may be a factor in the development of this health issue?
I wouldn't say the development of back pain, but I do think that people are misled into thinking that certain treatments will help them. And we've done some research on that, and there's a lot on the internet about, the benefits of injections, of surgeries, of things that are offered to people that aren't really effective on average. And I think, people, they search about the condition, they get served a lot of websites that talk about the benefits of spinal fusion, for example. And, why would you not then ask your general practitioner, your doctor, to refer you to a surgeon if that's a potential, effective treatment for you? And I do think that this leads people into making decisions about their healthcare that could be bad for them. That's for sure. And for example, on the topic of surgery, we published a study a couple of years ago looking at the sort of information that's websites from surgeons here in Australia. They what sort of information was available on those websites, and there were a lot of misleading information about the effectiveness of spinal fusion, like a lot of talks about complete recovery, and if you're in pain and you go on a website that talks about how surgery will completely get rid of your pain, of course you're going to be tempted to at least talk to someone about it. And I think, yes, I think it's a big issue, and people struggle with finding reliable information sources, and people don't know what's an evidence-based website, what's not, and it's just a complicated territory.
Do you think that we as physiotherapists, or not only physiotherapists, general practitioners, nurses, health professionals in general, we have the responsibility to start to make content available on internet, on social media, evidence-based content available to patients, to start to produce these correct messages about pain for patients?
Yeah, look, I think the more good quality content out there, the better, obviously, because more people will get exposed to it. I think there's, I don't know about Mexico and Spanish-speaking countries. I don't know of any good website in Portuguese that would give people evidence-based information, for example. Don't know about Spanish-speaking countries if there's anything, but there is a couple of very good websites that were developed here in Australia that have a very nice summary of the effectiveness and safety of a lot of treatments, and they provide patients with a lot of good guidance about what to expect and treatments to seek out and all that kind of thing. So I think also in terms, it would be good to promote those existing resources as well, because they've been developed, they're good. We know that they're evidence based. But yeah, I think the more the merrier, always. If anyone is interested in this website that I'm talking about, it's mybackpain.org.au. Have a look; it's a good one.
Okay, thank you for the recommendation, and yeah, we have to start to produce this evidence-based content on the internet. And well, we almost run out of time, but as last questions, I would like that you could give us key messages for physiotherapists. What are the key messages that physiotherapists need to keep in mind when treating a patient with low back pain?
Sure. Key messages. How many? You tell me.
I don't know, like 5 key messages.
5. Let's see if I can come up with 5.
Or if you want more, you can say more.
I think the first one is physiotherapists do an excellent job, and I don't know about the what the situation is in Mexico, but back in Brazil, you know, because physios are typically seen after they have to be referred by a doctor, usually, by a doctor. So there's a bit of a, you know, I guess like a power balance thing where the doctor, the surgeon sort of tells the patient they need to see a physio, and then they go, and the surgeon sometimes tells the patient what needs to be done in physio. So that's a bit of a weird thing. If that's the situation in Mexico, I don't really know. I want everyone to know that you guys do. We as a profession, we are amazing, and we can be really effective for a lot of people. And just having, you know, persistence and spreading the message of all the evidence-based stuff that we do, I think that's you know, just keep pushing through. That's message number one. Message number two is, in my opinion, you know, keeping it simple is the best thing to do. We are bombarded with courses, methods, approaches, X, Y, and Z that will cure your back pain. This complicated, you know, techniques that need years of practice. And yes, it's important to be trained and to have a wide range of tools that you can use with your patients. But at the end of the day, a lot of the times, the simple things will be the most effective. And I think patients appreciate when, you know, when they are treated with simple stuff that make a difference to their life. So keep it simple. Don't spend too much money on unnecessary weekend courses. That's message number two. Message number three, I think it's about that mindset thing that I was talking about before. I think we tend to assume that people's pain are not caused by anything serious. And sometimes based on that premise, we sort of skip, you know, a thorough history taking, a good physical examination. So my key message number three would be, do not do that. Always keep in mind that, you know, you need to become really good at interviewing patients, at picking up little signs that could, you know, point you towards something more serious going on. Always do your physical examination properly. Know by heart everything physical examination related. Message number four is listen to your patient's concerns. Try to understand for them what could be driving their pain and their disability. You know, when we talk a lot about biopsychosocial care, a lot of people will have only bio issues. A lot of people will have bio and psycho issues. A lot of people will only have social issues. You don't know, you can't, you know, you have to speak and listen to the patient before you can start putting the puzzle together. And that's going to make, I think, your treatment approach easier if you don't assume, if you listen first and then act together. Message number five is use research as a guide. Don't see research as a mandate. I need to follow research. I need to apply the results of this paper in my patients. If I don't, I'm not evidence-based. That's not how it should work. Research should be a compass, right? Which would tell you about what to expect more often than not, right? So if something is harmful in a trial, on average, it probably will be harmful to a patient. If it's not effective, chances are it won't be effective. If it's effective in a trial, it's more likely that it'll be effective for the patient in front of you, but it may not be. And I think you just have to keep your mind open to individual variations and use research as a guide, not as a mandate. That's really important. And that puts a lot of people off research when there's this idea that, you know, researchers are telling people what to do. We absolutely have no intention of telling anyone what to do. We're just trying to provide information and data so that clinicians can make their own decisions. And piece of information number 6, I think. I'll give you one extra.
Yeah, of course, we could say an extra point. This I think is 6, the 6 key message.
We do a lot of, in our group here at the Institute of Musculoskeletal Health at the University of Sydney, we do a lot of back pain and musculoskeletal pain research. If you want to spend some time with us, if you want to do some research with us, just get in touch and we would be more than happy to, to have you here spending some time with us. Carlos has had some experience in the past, and get in touch and we can take it from there.
Yes, when I was there, I have a very good experience, and I have learned a lot of research, back pain, and in physiotherapy in general. And talking about research and this engagement of physiotherapists in research, here in the Physiotherapy School of UNAM, we have students that are learning about research, methodology, statistics, and this science behind these studies about physiotherapy. So, as you, as an experienced researcher, what advice would you give to physiotherapy students who want to make research and to make their own research?
Right. Research is, as with any other job, as with anything else really, it requires a certain skill set. You need to understand certain things. You need to understand a little bit about study design, about study interpretation, and critical appraisal. So, you're going to have to dedicate some time to do these things. If you want to do research, if you just don't want to consume research, but also do research, your questions can be driven by what you see in your practice, but you also have to make sure that your questions haven't been answered already. And a lot of times that happens. Clinicians have all these interesting questions that they would like to pursue in their research, but then there's already been a number of studies, for example, looking into that very same question. So I think developing this ability to search for evidence, I guess Pedro has a lot of good tools on how to better search for evidence. It can help people a lot in that area. Having that skill set, knowing what and how to search for things, will clarify, I guess, a lot of the questions, and will make sure that the question you're asking hasn't been answered yet, and that your research will be unique. And I guess persistence. I don't know what the funding landscape is in Mexico. Back in Brazil, the funding landscape was really bad. There's not a lot of opportunity. So people sort of do research as a side gig, not as unless you have a university position, but that's really difficult to come about. So it's tough. There's other opportunities elsewhere, but having persistence, mastering certain skills that will make you a better researcher is important, and that takes time. So be kind to yourself when learning.
Of course, have a persistence and be patient. And study a lot. But it's a great experience. I have the opportunity to do some research, and I think it's a good activity, and it's funny and to learn a lot of new things. Well, so thank you so much. Thank you so much for being here with us. It was an interesting talk, and we learned a lot of back pain, the role of physiotherapists, and the concerns of patients, about evidence, about a lot of things. So thank you so much, Giovanni, for sharing your knowledge and expertise with us.
Thank you so much again, Carlos, for inviting me. I've had a lot of fun, and the questions were amazing. I really appreciate the opportunity to be with you here today. Thank you.
Okay, thank you so much. So see you next time.
See ya.